Is my slide visible?
Yes, it is visible.
Okay. So without wasting any time, my case of today is a lady with polyarthralgia after an episode of fever and rash. So I would rather give a lot of differential diagnosis in comparison to Professor Ghosh's earlier lecture. So which was rather a straightforward one. So this can be a whole lot of Pandora's box opening. So my flow of talk would be, what are the possibilities, brief description of some of the entities, which will cover most of my talk, how do I diagnose, just a slide or so, and what to do next. Now, what are the possibilities? It's obviously to everybody's mind, the infections run the most common differential diagnosis in this scenario. I would also add few others, which I'm not going to discuss in detail. Recent immunization that can lead to fever or feverishness with rash, followed by arthritis in some situations. Inflammation and autoimmune diseases like systemic lupus, vasculitis, and adult Still's disease. To start with, they present similarly. With time, we know what the child is going to be, a doctor, engineer, or a IT professional. But to start with, we don't know what the child is going to be in future. So these diseases should also be kept in mind in a lady of this age with this presentation. And last, but importantly, malignancy, which is really rare in adult. It's more common in children with leukemia, especially ALL, which can present with similar situations. But lymphoma and cutaneous T-cell leukemia sometimes can present with fever, rash, followed by arthritis. So the infections, the possibilities are a whole lot. Most of them are viral infections. Some are bacterial, rickettsial, and fungal, mycobacterial, and all of them. So of the viral, this is a very good slide from Nature Perspective published last year. So how does these present? Arthralgia and or myalgia, self-limited arthritis, and prolonged arthritis. So if you look at the infections like coronavirus and influenza, they can have fever followed by or associated with arthralgia and myalgia. They don't have a self-limited arthritis or prolonged arthritis, but we don't know really about coronavirus till now. With parvovirus B19, rubella, hepatitis B, we can get a self-limited arthritis, which is more common, but they can also present with arthralgia and myalgia together. With hepatitis C and alpha viruses, we can get a prolonged arthritis, which we see in chikungunya more commonly. Now, going to the brief description, parvovirus, hardly we think in adult, but they do occur. It's more common in children, but children presents with the skin signs more commonly. Adults present with polyarthralgia and joint swelling. It's more in a rheumatoid-like distribution. So to start with, there may be confusion in today's time when patients are presenting early. They usually experience sudden onset polyarthralgia or polyarthritis. The spinal involvement is quite uncommon. It is usually self-limited, but chronic B19 arthropathy may last for years, just like chikungunya, and cause confusion with rheumatoid arthritis. There is one odd point, which is that in parvovirus B19, the history of fever in adult sometimes is missed because and the rash is not there. Coming to the next one, which is rubella, it can be asymptomatic to a classic syndrome of low-grade fever, rash, coryza, malaise, and lymphadenopathy, which is very characteristic, posterior cervical, post-auricular, and occipital. The constitutional symptoms may precede the skin eruption by 5 days. The eruption may vary. It's more like a measles, more of a measles-like rash. The joint complaints are common in adult infections, especially in women, and they may occur 1 week before or after onset of the rash. The joint involvement is usually symmetric and may be migratory, resolving over a few days to 2 weeks at the max. Arthralgias are more common than frank arthritis. We get less of swelling and tenderness. Coming to hepatitis B and C, they can present with fever or malaise followed by arthritis. Rash is a little uncommon with hepatitis B and C, but they can have at times, especially hepatitis C. Acute onset polyarthritis in a rheumatoid-like distribution, including the small joints of hands, wrist, shoulder, knees, and hips, may occur with acute hepatitis C infection. It's also associated with type 2 cryoglobulinemia, which can present with purpura, livedo, digital ulcers, and may develop gangrene as well. a very important clue would be urticaria. So arthritis with urticaria can point towards a hepatitis B or sometimes hepatitis C infection. A more common disease would be chikungunya in our country, and chikungunya fever is explosive onset, which is known to almost all in this audience, with fever and severe arthralgia. The polyarthralgia is usually migratory and predominantly affects the small joints of hands, wrist, feet, and ankle. There are differences in different parts of the country. It was around 5 to 7 years back published in Rheumatic Clinics North America, the two different series from the South Asia and the Asian continent and the African series. So the African series, they commented more on hand swelling and Raynaud's phenomenon, while we get more of enthesitis and dactylitis and tenosynovitis. In severe cases, the symptoms may persist for months. Typically, the rash, as we know, it's 2 to 5 days, lasting for just a few days. And it's located on the torso, extremities, and sometimes missed in dark-skinned people like our country. Disseminated gonococcal infection, quite an odd in this lady possibly, but I really do not know because the rash has not been spoken about. It's just a rash. So DGI doesn't produce a widespread rash. It's a typical rash as I've shown in the picture. Tenosynovitis is a unique finding in gonococcal arthritis and usually not seen in any other form of septic arthritis. Coming to bacterial endocarditis, I don't have anything to say. This audience is possibly well versed with bacterial endocarditis and always consider bacterial endocarditis as a differential in someone who is having fever rash and arthritis or fever rash followed by arthritis. And with it comes the diagnosis of acute rheumatic fever and post-streptococcal reactive arthritis. But in those cases, the rash is usually evanescent or short-lasting. Scrub typhus, on the other hand, is a more common entity and more being recognized in our state. The clinical manifestations vary widely from children to adult, from mild to severe life-threatening illness. They can have macrophage activation syndrome and leading on to very severe disease. The regional lymphadenopathy, organomegaly, and gastrointestinal symptoms can be there. The eschar, if it is found at the site of the mite bite, gives a very good clue. But unfortunately, the incidence ranges from 7 to 70%. And in about 1/3 of patients, we don't get an eschar. And the diagnosis may be lying on the epidemiological perspective. Lyme's disease, possibly, we would not be considering a differential in our state. But Lyme's disease is being more and more reported in India, especially in the Northeast. They have started a compendium of this disease as well. So the symptoms may occur relatively early within few weeks of infection, such as arthralgia, myalgia, and mild transient arthritis of individual joints. However, the typical arthritis manifests in late phase. And the point to be noted is that polyarthritis is never observed in Lyme's disease. Brucella, they can hardly ever cause a rash. So I would rather not consider brucellosis as a differential diagnosis in this lady. Histoplasmosis, very odd, very rare, but they can present with rash, fever, followed by arthritis, but we should get a typical scenario. COVID-19 obviously would be because, and COVID-19 skin manifestations and joint manifestations are reported every day. We are getting case reports and case series, and we are yet to know the typical findings of COVID toe and the articarial rash and the purpuric rash that has been reported either with the disease or after the disease. And it should be considered in this time. The discussion would not be complete if I forget about mentioning reactive arthritis, because the typical history of a reactive arthritis is as it is told in this lady. But then it is basically a fever with infection followed by a rash and arthritis. Here this lady has having fever with rash followed by arthritis. So possibly the diagnosis of reactive arthritis would not be there. Just to show you, this is the typical keratoderma which we see. Adults still, as I told, can have a fever, rash, and arthritis, and it's difficult. It's mostly a disease of exclusion. HIV should always be considered because initial HIV infection may be associated with a transient flu-like illness with arthralgia. However, in later part, we can get the three typical pain syndromes, either acute symmetric polyarthritis, a subacute oligoarticular, and a typical painful articular syndrome. The discussion would not be complete again, as I was saying in the beginning, that vaccine-induced arthritis is also always a possibility, and the very easy history of vaccination would give us the answer. This is typical with rubella. The manifestations are same as the natural infection. The arthritis usually occurs 2 weeks after the inoculation and typically lasts less than a week. In some cases, it may persist for more than a year. And this occurs to a tune of 15 to 25%, not very uncommon. Before I go to the issue of a virus-triggered autoimmunity, I must also mention that fever, rash followed by polyarthritis can also be a infection-associated arthritis, and the rash being a drug-induced rash. We should not forget a drug rash in this patient as well. The issue of virus-triggered autoimmunity should always be there. For example, with P19 arthropathy and the chikungunya, as well as the COVID-19. So we know that most of the autoimmune diseases, they are triggered by a viral etiology, and the viral infections actually causes the arthritis by an autoimmune mechanism. So there is an overlap and there is a gray area between them. And this leads to a confounding serology of the autoimmune diseases. So the rheumatoid factor may be present in low to moderate titer, for example, in a parvovirus infection. This is just an example, but this can occur in any other disease as well. And the ANA can be positive. Now, this autoimmune serology positivity actually leads us to confusion. And this is the reason why the wait and watch policy for such a short illness should be maintained. And we should look beyond the patient. Most of the time, the diagnosis lies in the news. For example, if we get an epidemic occurring in Kerala with a virus, or in Pune with a chikungunya epidemic, and we are getting a patient from there, we can obviously label that it may be a chikungunya followed by arthritis. So we should look beyond the patient. So how do we diagnose? By clinical examination, and before examination, as I said, we can wait and watch, and we can go for microbial serology with the antibodies against the microbial microbes, and sometimes the testing for the genome like a PCR. But many a times these are not available in our country, at least in our part of the country, and we are left with a clinical diagnosis most of the time. How do we treat them? Quite easy, but at times frustrating. The more common dictum is wait and watch, because they are going to be self-limiting in some time, and giving paracetamol and NSAIDs would suffice. For some of these viral arthritis, we can give corticosteroids for a short term, and then that can cut down the illness, and that can also cut down the autoimmune phenomenon. For some of the patients like chikungunya arthritis and chronic parvo B19, we might attempt for a disease-modifying drug therapy, but that's a discussion for another day. So thank you very much for the patient hearing.